brains behind the love seat here, Robin Miller, is going to talk to us about a kind of a scary condition, the development of RV dysfunction and failure after Impella 5.5 support.
I mean, how do I follow that? I mean, we started with you have no guidelines, and then I get the RV failure where we sure as heck have no guidelines to help us decide where to move. So yes, I'm Robin. Thank you for inviting me out. Well, I really didn't get... Thank you for voluntolding me out and having me be up here. And I'm going to talk about my RV is failing on an Impella, and I did do a 5.5 because we are a big 5.5 center. So now what do I do? Let's see if I can figure out these slides. Disclosures. So my founding principles for RV support actually follow what we kind of lend ourselves to cardiogenic shock decision-making in and of itself. You have to identify early that a patient is in RV failure and recognizing whether this is acute or chronic. You have to do really early hemodynamic profile, and I actually joked earlier, see who is in the room. I love PA caths. I am a proponent of hemodynamics. I know there is a large debate about that. We should escalate to early MCS should they need that for right-sided support. We need to optimize them, and the goal is going to be recovery of end organ function and or recovery to the point of getting them well enough to get to transplant if that is their only end result or end option. So early recognition, I'm sorry, I'm a mover. Is this on? Can I just talk this way? So early recognition is the most important piece of our RV failing. So Amanda is going to do a talk about my Impella is alarming at 2 a.m. What the heck do I do? Most commonly that is, I don't know why, but my 5.5 keeps suctioning. I can't figure it out. They've been fine at P7, and all the time I have to drop down my P levels, break the suction. The blood pressures are fine, so I just go right back on up. But really, you have to decide whether or not the RV is able to support that LV that is now working. I traumatize my NP fellows all the time by giving them the analogy of walking a dog. I'm going to traumatize everyone in this room. When we put in an LVAD, we essentially, or in this case, our mechanical circular support, our Impella 5.5, we essentially give the left ventricle the best support it can have. So I'm walking my dog. I am the left ventricle. My dog is the right ventricle. My dog's old. He's turning 10 this year. We kind of go slow. He kind of piddles and keeps up with me. But we're going to say Jason comes on and asks me if I want to ride home. Really nice of him, starting to rain. And so I jump in, and he takes off at 30 miles an hour while I have my dog outside the door. And it is just being dragged along behind me. Where, if I did this a little bit nicer to my dog, I had Jason pick me up, but only go about 5 miles an hour, and my dog slowly is able to accommodate to having that 5.5 or the car taking off. It's essentially what happens when we put a device in our patients. We have a globally typically myopathic process. Our RVs are not typically uniquely or normal, especially in our chronic heart failure patients who go on support. We give them, essentially, we turn it up to 11 for anyone who is old enough to know a spinal tap reference, and I'm going to be really sad if no one knows that. But we turn it up to 11. We essentially give them the best support possible on the left side, and their right side just simply can't keep up. So when we think about why patients have RV dysfunction, again, we say, is it because of a chronic process, chronic RV failure, chronic pulmonary venous hypertension that has led to pulmonary hypertension over time that is fixed, or is it acute? Have they acutely had something go down? Are they an ischemic and they've now lost that flow? Are they someone who has developed a PE? We do see that quite commonly in our patients. Are we someone who has some other reason for that afterload to be increased? Did someone decide that the patient needed PEEP of 14 for reasons that are unknown to us in our mechanically ventilated patients? So recognizing why our patients have that and then deciding, okay, how can I help guide management? Do I, and how do I, fix them? We know that hemodynamic assessments, as you see here, we know that hemodynamic status, especially using invasive hemodynamics, PA catheters, can improve mortality. And we know that we have quote-unquote quasi-definitions for what RV dysfunction is and severe RV dysfunction is. And if you look at this, RA pressure greater than 10, our PAPI less than 2, our RA and wedge ratio greater than 0.6. That's actually a Tuesday for many of us who are in the advanced heart failure and or shock world. These are patients who may actually be walking around with these normal hemodynamics. But when we get to the severe RV dysfunction, their RA pressures continue to rise. They continue to have lowering or drop in their PAPI. These patients are at risk for developing RV failure and need to have support. So what kind of support is there? No one laughed. This I also did on the plane, but I had internet, Joyce. I'm really sorry. So when we talk about what our course of action is, the first thing is hemodynamic assessment. We have to know what those hemodynamics say. We also have to get an echo, because the first question is my Impella actually positioned correctly? Is everything that I'm seeing, worsening renal function, more hypotension, rising lactate, simply because I'm actually malperfusing them with the therapy that I've given them? If that isn't the case, our echo is well positioned, but we're noticing that we're having more RV dysfunction, then getting labs, very important. We do need to know what that end organ function is, and then also getting a PA cath in place if one is already not there. And then we decide, which venue do we take? Do we optimize preload? Do we, as a patient, despite being on, at least at my institution, 20 of Lasix an hour, diarylogram, BID, still not peeing well, do we need to actually give them more diuresis or start diuresis? Or do we need to actually start ultrafiltration in whatever capacity that is? If we have patients who are not on inotropic support, do they simply need more contractility? Can we add inotropes? And we also, our milrinone and dobutamine are the ones that we go for. Can we improve their contractility? And then if we're actually worried about afterload, especially in our chronic heart failure patients or those with pulmonary hypertension, can we start pulmonary vasodilators? And whether that is, hopefully not sildenafil because it's very selecting, but typically inhaled and or even using milrinone for pulmonary hypertension, does that improve their forward flow? And if the answer is no, they're having worsening hypotension, they continue to have an RA that's elevated, they're showing evidence of poor organ perfusion, we need to add right-sided support. And this adage is really kind of where I say the same thing that Dr. Wald said earlier, and same thing that Marwin said, is that at 4 hours, if you put a drug on and it doesn't work, you get temporary MCS. If at 12 hours on temporary MCS, you're continuing to get worse, something's wrong and we need to consider the next step. So in this case, what ARVADs you have are really dependent on your facility. My facility, we're very lucky, we're a community hospital, but we do comprehensive cardiovascular care, including transplant. So we have the option for an RP Flex, a Protect cannula attached to a Centromag. We don't use Tandem obviously anymore. And then the next question is, if with that hypoxia, with that elevated RA pressure, with that hypotension, with that elevated RA pressure, if our patient also has hypoxia, we'll immediately move to VA ECMO, leave the 5.5 in place as our LV vent, because the ultimate goal is that we need to recover them. So I was trying to get us back on track with time. So final points are, need to recognize RV dysfunction early before it becomes RV failure. We need continuous hemodynamic measurement because assessments really do impact that mortality. And the goal of everything we do is recovery of end organ function with hopefully the potential of recovery of that patient. And that's it. I'm going to sit back down because I have this.
Down. Are there any questions from the audience at all? Or from our panelists?
Yeah, one of my questions. So we use a lot of nitric oxide here. We are very liberal with the usage of nitric oxide. Regarding the device, if you hear my mic is on.
I think it's working now.
Okay, regarding the device, the LivaNova is withdrawing the tandem heart and the LifeSpark from the market. So are you expecting more usage of the RP Flex or?
Yeah, Abiomed, close your ears. We use both the RP Flex and the Protect cannula. Our early center experience, we've done 29 now RP Flexes, and we used to do the Protect to the tandem. We've seen more hemolysis in our RP Flex patients than we have in our Protect patients. And so for patients who need BiVAD support, who we think are going to be sustained for a long period of time, we do use nitric. We use everything prior to going on to mechanical support. We'll actually do a Protect to a Centromag, consolidate everything onto one cart. I wish I had brought a video. We have a patient right now, he's a 33-year-old, walking around with a BiVAD waiting for transplant, and that's our typical configuration. We used to do Protect to Tandem, obviously, before the ACS division closed.
That's how we used to do more.
Yeah.
Thank
I was
you.
going to say the RP Flex, our center I think doesn't use them as often because of that mobility problem. Their femoral access for the most part.
We
So
just started to
yeah,
use it.
yeah. So our physicians are very pro PT and OT. We joke that we're a rehab unit, but it's an important part of their recovery is getting strong, getting nutrition. All that stuff is so important as we go forward, particularly towards transplant or a durable LVAD, to get that support in a way that they can move around and be active and do the things that they need to do and not get skin sores on their bottom from laying. So
Yeah, we just now get these skin sores on the head from having to attach the large cannula that essentially is all of your body outside.
But that should be the benefit of the RP Flex
It
over
is
the,
the
over the
benefit
old
of the RP
RP,
Flex,
which was
yeah.
all femoral, right? I mean,
Yeah.
good. And are there any other questions or thoughts from there? I do have, and I know what your answer is going to be, but I figure you might as well say it to everyone. You want to be vigilant for monitoring for RV dysfunction and RV failure in the patients that's supported with univentricular support on the left side. So do you make sure to put a swan and get invasive hemodynamics on all of your left-sided temporary supported patients so that you can be more vigilant to monitor for what can be a really disastrous complication?
We do. So for the first 72 hours, irrespective of the device, whether it's a femoral CP, femoral balloon, axillary Impella, everyone has a PA catheter in our ICU. And then at that time, we will, if we think that we are not going to wean, we will take it out and give them a line holiday. But if we always do weaning with PA catheters in place. And so it really does depend on that patient. But yes, and if we ever have a question, we put a PA cath back in.
Great. And then a corollary or a follow-up to that question, do you leverage a multidisciplinary shock team to help you make some of those decisions, or at least in a collaboration with your advanced heart failure and surgical teams? Because, obviously, once you commit to biventricular temporary support, then that's a giant leap forward where you now need an exit strategy, and in many cases that's some heart replacement therapy.
Yeah, we actually do it for all devices. So any device that is going to be placed, even if it's in the cath lab in the middle of a STEMI, we actually activate our shock team, which is made up of our shock coordinator, shock APP. We have our advanced heart failure attending, our cardiac surgeon, our cardiac CICU charge nurse, because they need to tell us if we can actually do what we think we're going to do. And we actually meet at the bedside, review the data, and decide what device and if it's even possible.
Awesome.
We also decide if it's someone, say, who isn't a candidate for anything, we'll give a time-limited trial, and that's actually in our consents that we give to patient family members to sign.
Awesome. That's amazing. That is amazing. Great.
Yeah.
Should we move
We'll
along?
move on, yes.
Great job.